Okay, so chromosomal abnormalities. These do not go into too much detail for purposes of the exam, okay? You will not be, in terms of some of the general ones, okay? We're going to talk about the major ones in this PowerPoint that I want you to really focus on for the exam. But in your book, you'll find there's a whole list of them. There's actually a table, and you do not need to do all of that, all that's on the table. Focus on what's in the PowerPoint, which should also match what's on your syllabus. Okay? What we mean by chromosomal abnormalities is that this is either, obviously that you're supposed to have a dyad, you're supposed to have two genes on every 46, you have 46 chromosomes, they're supposed to be paired up, right? So this is when you have either an extra one, which would be a trisomy, or one less, which would be a monosomy, okay? And this would lead to some sort of chromosomal abnormality. What is most frequently the reason for this?
Exposure to teratogen.
That could be it, and also maternal age, advanced maternal age has been one of the things that has been connected with this a lot. Because again, those are the kind of things that would, over time you're being exposed to more things. Your eggs are aging as people age. So these are some of the things that would contribute to this.
Graduate already. My eggs are aging.
Yes. She'll tell you your eggs are dying. So Turner syndrome, you do want to kind of read up on and know about it. Turner syndrome means you have an X and that's it on the sex chromosome. So females are what? XX. And males are? XY. Well, this child is X, only one X. So when you have one X, what is that manifest like?
Male pregnancy.
Well, truly, this is a female patient, but with some androgynous or some mixed manifestations. So, for example, in utero, the fetus develops, and in the very beginning, it develops, they either become testicles or you have ovaries, right, when you talk about the sexual organs, okay? So it's all about that development. You have what could become the clitoris or what could become the penis, right, when we talk about, the development of the sexual organs. So in this case, they're a shorter stature, they have a webbed neck, which means like a thinner, extra fold of tissue on the neck. Gonadal dysgenesis. So basically what that means is there are ovaries present, but they are not functioning, they are not fully formed, and they usually don't have eggs or release hormones. Okay? They have a cubitus valgus, which is elbows turned out, and a very enlarged clitoris, which many times on birth may lead healthcare providers to think, male or female, not quite sure male or female. And then they do genetic testing to check. And 25% actually have vascular malformations, like aortic stenosis and even heart conditions, congenital heart defects. Those 25% have a lower prognosis, obviously. The prognosis is very good for this. It's more about the psychosocial components that are attached with this. But the 25% that have vascular malformations do have higher risk of death.
Do they know where who doesn't supply the X? Where does the X go?
It's usually on the female end. This is very much tied with advanced.
That egg is just missing an X.
That's right, on that gene. So the X was given from the father, but there's nothing from the mother, on the mother's end.
Usually, most of the time.
That's what they pretty much, yeah. That's pretty much what they say.
Is this related to hermaphroditism at all?
This is a lot of times when people use that term. That is a social term. It's not like a medical term, but yes, when people say that, that's usually what they're talking about. Like ambiguous genitalia, this is what a lot of these patients have. Although we will talk about Klinefelters, which is another one too. So what do we do for these patients? Well, first thing is about the bonding with the parents, because what's one of the first questions parents usually ask when their child is born if they don't already know?
It's a boy or girl.
That's right. And so think of how stressful it is for the parents and how distressing it can be for them when, this is something that, they didn't anticipate, and now they have to, they manage it. So bonding with the parents, because again, these children are usually medically stable 75% of the time. So usually it's about the bonding with the parents that we want to make occur, make sure that happens. Go ahead.
Those characteristics are visible in birth already, or are visible when they mature?
The ambiguous genitalia is definitely what's most visible at birth. Some of the other things are not as visible, though definitely the lower hairline I've seen and the webbed biceps, neck, very early on, you know, so some of the things are, but definitely the shorter stature obviously will be later on. Does anybody know why you would have shorter stature in these patients? Any thoughts about that?
They're shorter than regular women.
That's right.
Does that have to do with testosterone?
Decreased testosterone?
Well, you're on the right track. The sexual hormones actually stimulate the growth hormones. So in puberty, when you have a spurt of growth hormone, a spurt of the sexual hormones in puberty, that actually spurs on the growth spurt and kind of helps to increase the growth hormone. So if you don't have that spurt of sexual hormones that naturally occurs, growth hormone itself won't be naturally, so that's why people hit the growth spurt, you know, when they hit that puberty and all. So that's why they have a shorter stature. So what do we do for these patients? Well, it really is about giving hormone replacements. You know, usually they're sterile, they're not able to have children themselves. But what they do is fairly early on, they do start giving them some hormones. You know, they can take oral, usually injections as they're younger, and as they get older, they give them oral hormones to take. And what that will do is it will just help them to develop more feminine features. So they'll actually give them hormones that can actually help with breast development. It can actually help with, you know, a lot of these other, like giving them more feminine features, which will help because they won't have any of their own hormone development.
Okay, recently having BBS genitalia, and sometimes they'll have to do a test to determine the gender of the baby. And then for the hormone replacement, why do they actually go, trying to give them more feminine features? Is that because they have ovaries? Or when both have ovaries anyway, or?
Oh, why are they making it? Well,
Yeah.
they are female. Yes.
They are female,
That's the
they're
question.
always female.
They are female with just the X. They have ovaries. They're just not really formed ovaries.
Okay.
And some people, I guess, could argue that they are that they could be because again, the sexual organs could go either way. You know, it's really with the development of the XX or the XY. But what they've pretty much done in the medical field is with this, they pretty much have determined they've without that Y there, they're pretty much female.
Okay.
That really does differentiate a little bit more so. And we'll get to a point where we're going to see XXY. And because there's a Y in there, that's Klinefelter's. And because there is a Y in there, they are definitely male. Exactly. So it's the Y that sets it off. So Klinefelter's, you have the XXY, and this you have the X only. And that's why they give the female hormones. What you're bringing up, though, your name again? Crystal, what you're bringing up is a great point. There's a lot of documentaries, there's a lot of research on children who've been born with some of these diagnoses as adults, feel very ambiguous about their own sexuality and about their own gender. So it does become a very hard, psychologically, it's very difficult diagnosis for them too. So what I would want to leave you with this is it's not just about the hormone replacements, but it's about the lifelong follow-up with the family and the child, and as they mature and grow, it's all about, you know, all the support and counseling they would need, you know, because it is again, it's difficult for school, it's difficult for peers, it's difficult for them when they are trying to feel like they fit in, right? We talk about, you know, identity versus role confusion, right? We talk about adolescence. So think about all these challenges in normal development that we spoke about, and now you have this thrown into it. And that's where, you know, a lot of these things become difficult. And again, Klinefelter's, as I mentioned, is XXY. So very distinctly male because of the Y, but again have very small testicles and dysgenesis there too. They can be sterile. They can actually have cryptorchidism, which means undescended testes, you know, which don't descend on their own at all. Gynecomastia, which means what? Exactly. And again, they give them testosterone, and that actually helps with. Now, many times there are some other, with Klinefelter syndrome, there can actually be a mental retardation that can occur too. So there can be some lowered IQ with this also.
Not returners?
Not so much with Turner's, no. More with this. Turner's has a small percentage, I think it's 12%. This has a much higher percentage. And then the malformed ears, again, very, very common. Going back to what you asked, this is very features that you can see right at birth. Microcephaly, okay, smaller heads that seen right at birth too.